Vanakkam. Welcome to this course on biomedical instrumentation. We have been looking at EEG in what is perhaps the last segment or last video of EEG. We will look at abnormal EEG patterns and artifacts in EEG. Remember our comparison of EEG measurement to the stadium. Now let us compare this stadium and crowded stadium situation to a slightly different this. Consider an orchestra. Instead of different instruments playing their own note or their own at their own level, assume that all the instrumentalists are playing exactly the same note at the loudest volume, at the highest volume. That is a form of hypersynchronous activity that happens, that can be equalized or compared with epilepsy. So, harmonious music does not mean that everybody is playing the same note at the same volume. No. If you hear harmonious music, melodious music, you will realize that at specific points, specific instrument volume is more than some other instrument's volume. Specific instruments are playing specific notes. Together, the synthesis is what creates that mellifluous, pleasant music. It does not mean that they are all playing the same note at the loudest volume. If they do, then that is not harmonious, right? Likewise, different neurons are performing different functions and are active at different levels. That is harmony. If all the neurons, or if a large number of neurons in a given small region are simultaneously active at their highest rate, that is called as abnormal activity or epileptiform activity. The exact reasons behind epilepsy are beyond the scope of this course. The pathophysiology of epilepsy are beyond the scope of this course. This is a course on instrumentation, but let us at least try to understand what causes this, or what are the various types of this. Epileptiform discharges, spikes and sharp waves are generally indicative of epilepsy. If there is a spike, generally there is a spike here, there is a spike, this. These spikes are generally indicative of epilepsy, but note that there might be spikes that do not signify epilepsy. Spikes alone does not mean that there is epilepsy. There are the so called benign spikes that are present. These are spikes that are found in normal healthy people who do not have epilepsy, but they will still have spikes in EEG, that is there. And then slow waves, slow EEG waves are generally, slow waves are dangerous EEG waves. Dangerous means theta, delta. Slow waves are generally associated with brain injury and nearing coma type, losing consciousness, going unconscious, generally associated with brain injury and encephalopathy. Burst suppression is generally seen in comatose patients and people with severe brain injury. Okay. Focal abnormalities that are present are essentially localized disruptions in brain activities that are sometimes present in some cases of epilepsy. So, note that if someone has normal EEG, that does not mean that the person does not have epilepsy. In the clinic, generally, the EEG session per session EEG recordings are only about 30 to 50% sensitive to epilepsy. So, the person may have epilepsy, but may show relatively normal EEG, or the person may not have epilepsy, but will show spikes, the benign spikes. So, essentially everything. The person may not have epilepsy, but will show benign spikes. The person may have epilepsy, but the EEG will appear normal in about 30 to 50% of the cases, which is why multi-session recordings are needed. And you also need to correlate it with other clinical examinations. EEG by alone is not, although the gold standard of epilepsy diagnosis, by itself is only having so much sensitivity and specificity. I already mentioned, the person may have disease, we may not be able to detect. The person may not have disease, but it might be classified as disease. We have to be cautious. So, which is why it is important to have the medical professional correlate multiple observations or from data from multiple sessions. That is why it is important. So, what is the interpretation? These essentially helps and diagnose these neurological conditions like epilepsy and guide appropriate treatment decisions. What is epilepsy? It is a disorder that is characterized by recurrent unprovoked seizures that are caused by relatively not normal, abnormal activity, electrical activity in the brain. This is the normal activity, it starts in this point and then ends, that is normal activity. Abnormal activity, you see, abnormal activity going again, firing this. Okay. This abnormal electrical activity in the brain, unprovoked seizures. There are different types of seizures. Focal seizures usually originate from a small region in the brain. Right. Earlier believed to be the RAS system. The research is evolving. Then the generalized seizures essentially involve the entire brain. Activation happens over the entire brain. Many people assume that if there is generalized seizure, then the person will always fall unconscious. No, this is not necessary. The person may have generalized seizure, but may still have consciousness. That is also there. So, all kinds of variations are there. Generalized epilepsy usually involves the entire brain and consciousness is usually lost, not always lost. Consciousness is usually lost. Okay. The person may have seizure, but may not lose consciousness, or there are such cases. Then partial epilepsy is the case in which seizures originate from a specific region of the brain. There are two subtypes of generalized seizures or generalized epilepsy. The grand mal epilepsy, not grandma, grand mal epilepsy, which is essentially the tonic-clonic epilepsy. This is the classic convulsive seizures. The person, you will feel that the person is showing this seizure, fits, that classic convulsive seizures, and then the petit mal epilepsy, that is going to show EEG of this type. Note the change in the scale of the y-axis, also the frequency ranges. Okay. Petit mal epilepsy usually involves brief, sudden lapses in consciousness or concentration. This actually happens to many of us, right? Suddenly you lose focus, especially in today's world you lose focus because of 100 different reasons, but that does not mean that you have epilepsy. Okay. You lose focus or you lose consciousness or you lose sudden blank, that does not mean that you have epilepsy. It just means that you have been watching the phone for a long time. Okay. Coming back to epilepsy, there is a brief sudden lapse of consciousness that happens. This is called as the petit mal epilepsy. Then there are partial epilepsy subtypes. One more thing before we move on to partial epilepsy is that, you know, seizures, sometimes people think that seizures always involve convulsive fits. That is not necessary. There are seizures that may simply cause blanking of the awareness, but the person may not show physical fits or convulsions that may not be seen. So, that is another common misconception. Going back to partial epilepsy and its subtypes, the so called Jacksonian epilepsy or the Jacksonian march. It starts with the localized activity, motor activity in a region and then spreads to other regions. This is called as Jacksonian march. March, as if soldiers are marching, that march, not march the month. Soldiers are marching, like that epilepsy is marching from one region to another region. This essentially, this is of course suggested, named after Hewlings-Jackson. This essentially led to Hewlings-Jackson hypothesizing that there is a region just anterior to the central sulcus that is responsible for, that is having a causal role in movement related activity, essentially first identifying the critical role of motor cortex or primary motor cortex M1 in movement related activity was first properly hypothesized and framed based on his observations. Such a brilliant observation. Based on his observation of these epilepsy patients, partial epilepsy patients, he hypothesized that the region just anterior to the central sulcus, which is essentially the primary motor cortex, has a causal role in movement control. It's a hypothesis that was framed in the 1890s. Now we know that indeed the motor cortex, the primary motor cortex has crucial causal role in motor control, something that we now know, but to make this observation in 1890s is essentially sheer brilliance. Right. Then you have psychomotor epilepsy. This is essentially characterized by a bunch of complex behavioral and impaired awareness, sudden loss of awareness, complex behaviors. This is psychomotor epilepsy. Then you have the details of the tonic-clonic or grand mal epilepsy. Tonic-clonic epilepsy, this essentially has a tonic phase in which there is a stiffening of the muscles and the loss of consciousness, usually the loss of consciousness. And then there is a clonic phase. Tonic means stiffening, tightening. Tonic means tonic. Clonic means clonic. This one, cyclic movements, rhythmic movements are clonic. Tonic means constant motion. For details of these, refer to my other course on neuroscience of human movements and classics in neuroscience, in which I discuss this. After the ictal state, after the seizure episode, post-ictal state it says, post-ictal means after the seizure, ictal means seizure, post-ictal means after the seizure state, people are confused and tired and fatigued after the seizure. In petit mal or absence epilepsy, it usually lasts for a few seconds, brief absence of consciousness, brief loss of consciousness, 5 to 10 seconds of consciousness, sometimes also caused due to panic depression, depressive disorders. So, not to be confused with panic depressive disorders and other such psychiatric problems. This is epilepsy. Sometimes there will be a brief loss of consciousness that some people may have, that may not be related to epilepsy itself, that might be a psychiatric problem, might be due to panic disorder, for example. Sudden loss of awareness with absolutely no convulsions, sometimes often mistaken for daydreaming or falling asleep for a few seconds. It is quite common in children. This petit mal epilepsy is quite common in children. The other is psychomotor epilepsy, which is a complex disorder having both loss of awareness and other psychological this, and also convulsions. Typically originates from the temporal lobe, repetitive automatic behaviors, lip smacking, hand movements, repetitive behaviors. This is the psychomotor case, sometimes accompanied by impaired consciousness and impaired awareness, can last several minutes. After the ictal phase, post-ictal phase, patient might be confused and have absolutely no memory of what happened during the seizure. Right. Then Jacksonian march or simple partial seizure often begins in the motor cortex, starts with localized twitching in one body part, say the hand or the face, and then it spreads to the other part along one side of the body in a marching pattern, also called as the Jacksonian march. This is called as the Jacksonian march. Usually consciousness is present during this seizure, and sometimes a prognosis is that sometimes it can evolve into generalized seizures. From partial seizure it can evolve into generalized seizure. Artifacts, right. Note that the electrodes that you use in recording to record EEG, they do not know what electrical signal, what is the source or origin of the electrical signal that they receive. Sometimes the electrical signal may not be of cerebral origin. Any electrical signal or any recorded activity that is not of cerebral origin is termed as an artifact, and it can be divided into physiological artifact, those that are generated from within the person, the participant, from sources other than the brain, might be a movement or this, or extra physiological artifact. This might be happening from outside the body, including the clinical environment in which the person is. The huge challenge, biggest challenge in EEG signal processing is artifact recognition and removal of artifacts. Some patient related artifacts such as movement artifact, sweating, ECG for example has common frequency components with EEG. Of course, the amplitude components are not the same, but it may corrupt EEG. Eye movements, blinking might corrupt EEG. And technical artifacts, for example, the common mode noise of the power line interference, right. Cable movements, and electrode paste related, paste may dry out or paste might not be sufficient, contact might be lost, and other such things which will have to be handled appropriately. Note that some of these can be eliminated by having an active electrode. For example, avoiding this cable movement related artifact is possible through by having an amplifier right on top of the electrode itself, thus minimizing, because movement related cable movement related artifacts have certain amplitudes that are much less than the amplitudes of the amplified electrode potentials, something to keep in mind. Okay. These are the various EEG artifacts. For example, eye blink, eye movements, REM sleep, during REM sleep, these are ocular type, these are physiological, and then scalp contractions. When I am blinking or when I am doing something, it is not possible for a person to be completely immobile. A person is completely immobile only when they are dead. Okay. Scalp contraction or glossokinetic artifacts due to muscle activation, chewing or talking as the person is these are all attributed to, see, you might be swallowing saliva, but that is a movement. It is not possible for you to not swallow saliva for a long time, especially in hours long recording such as the sleep studies, for example, right. These are all internal related to physiological movements or tongue movements and muscle activity, and then talking related to, then electrocardiograph related to the cardiac activity, ECG, EKG or ECG, or swallowing of saliva or swallowing some food or something. Swallowing is swallowing, any swallowing. Then respiration, it is not like you can stop breathing while taking EEG. You have to do that. Essentially causes movement in the nasal pathways and in the face, and also some relative movements in the head from where you are measuring, essentially a physiological origin. Then galvanic skin response, sweat response, electrode movements may be due to something that is happening in the environment, electrode impedance imbalance, maybe gel has dried out, or this cable is moving, electromagnetic interference, some magnetic interference of some other activity that is happening in the clinical setting, power line interference, head movement, body movement, limb movement are all sometimes may be due to other extra physiological, or may some of these are due to physiological sources, some of these are extra physiological. These are all the various possible artifacts. We have to consider all these artifacts and have them removed before we move on. So, with this we come to the end of this video. In this video we looked at abnormal EEG patterns, especially the epileptiform EEG patterns, and what are the various types of the EEG. We classified these, grand mal, petit mal, partial epilepsy, absence, and the Jacksonian march, those we looked at, and then we looked at the sources of artifacts in EEG. The biggest signal processing challenge is the removal of artifacts from EEG signal. With this we come to the end of this video. With this we also end our segment and discussion on EEG. Thank you very much for your attention.